Thank you everyone for being here with us today. My name is Joanne Jung. I'm Associate Professor, Visiting Faculty at the National University of Singapore, Yong Loo Lin School of Medicine. And I'm delighted to welcome so many of you from around the world here today to the inaugural webinar of our series on Behavioural and Implementation Science, Innovations for Healthcare at the Yong Loo Lin School of Medicine. This is the first of a series of webinars led by the Behavioural and Implementation Science Initiative Center, a new center at the School of Medicine dedicated to bringing these two sciences together to advance the practice and policy of healthcare in Singapore and beyond. We aim to improve population health and well-being by accelerating implementation and innovation that's evidence-driven. And in order to open our webinar today, I'd like to invite Professor Chong Seng, the Lien Ying Chow Professor in Medicine and Dean of the School of Medicine, who has been a driving force behind the opening of this center, to commence our webinar with his welcome address. Professor Chong, please.
A very good afternoon to our distinguished speakers, Professor David Halpern, Professor Nick Zepdalis, Associate Professor Robin Milden, our webinar host and moderator, Dr. Joanne Jung, guests, colleagues, ladies and gentlemen. Welcome to the inaugural episode of our webinar series, Innovations in Behavioral and Implementation Science for Healthcare. Traditionally, medicine and healthcare has been mainly about understanding the biology of and delivering effective treatments for diseases. Yet we see that having the cure for diseases does not always translate to better health or well-being. The Center for Behavioral and Implementation Sciences Interventions, or BISI for short, was established by the NUS Yong Loo Lin School of Medicine in 2019 to improve the effectiveness of medical and population health interventions by incorporating behavioral and implementation science approaches into healthcare and population health practices. Fighting COVID-19 over the last 20 months, and now trying to learn to live with it, we have seen up close the importance of individual behaviors and choices in determining the course of the pandemic. We've also become acutely aware of how important the implementation strategies of public health authorities are in the success of efforts to control COVID-19. Not paying attention to natural human behaviors or the intricacies of implementation has generally led to failures of public health measures, even with the best funding and intentions. Moving forward, there's a need to educate healthcare professionals about the science behind behavioral insights and implementation strategies. Starting from the undergraduate level, behavioral and implementation science will be incorporated into the medical curriculum for students to understand these important concepts and how to apply them in patient care. BISI will also be developing continuing education and training for healthcare professionals and public health practitioners so that we can incorporate these important disciplines into our health systems. Beyond training, BISI will also be doing primary research and intervention studies to further the field in Singapore. To this end, BISI has established seed grants to support the development of behavioral and implementation science capabilities in small-scale research studies and enable them to go into larger-scale projects in Singapore. For interested participants, more details on this will be shared during this webinar. Lastly, I would like to extend my appreciation to the team who have been involved in the establishment of BISI and the organizing committee who have made this webinar possible. I wish all our participants an engaging and insightful webinar. Thank you.
Thank you so much, Prof. Chong, for those remarks, and also again for all your support in getting the center launched. I'd like to just take a couple of minutes before we get started to just follow up on the seed grant mechanism. I do see that many of you here are part of our NUHS family. So for those of you who are part of the National University Hospital System here in Singapore, our seed grant mechanism is one of the first initiatives that BISI will be launching to grow this ecosystem within our cluster. And so if you are interested, please apply for the seed grant. This requires the submission of a letter of intent by October 2021. All individuals who are shortlisted will participate in an implementation and behavioral science workshop in November, following which final grant applications will be taken in the first quarter of 2022. This grant mechanism will involve a mentorship with our senior faculty, and that hopefully leads us to applications for larger grants in the future. And so this is the first step that we foresee in bringing this community of researchers together. Thank you so much, Nina. So without further ado, I think we'll get started with our panel session. this session today will be a discussion among our three major speakers who are the senior faculty of our center. I'd like to introduce them one by one. We have Associate Professor Robin Milden, who is the co-director of the center. She is the executive director also of the Center for Evidence and Implementation, CEI. We have with us also Professor Nick Sebdalis, who is director for the Center of Implementation Science at King's College London, and Professor David Halpern, the chief executive of the Behavioural Insights team. So our discussion today will be a panel discussion among the three speakers. I'd like to remind our attendees that your questions are an important part of this session. So please share with us any questions that you would like to pose to the panelists in the question and answer box, which you will see at the bottom of the Zoom screen as we go along. So the session will last between 3:15 and 3:55. So if you do have questions, don't hold them to the end. Send them as we go along, and we'll have the panelists respond as we can. And what we're going to do is kick off the session today, starting with their thoughts on what they feel have been the most striking recent applications of behavioral and implementation science today. As Professor Chong said, we are living in unprecedented times. We're dealing with the COVID-19 pandemic and the switch in mindset from pandemic to endemic conditions. We're dealing with unprecedented public health challenges. And at the same time, we are still dealing with the issues of health system resilience and strengthening that we've always had before. We face the continued sort of demographic change, aging populations, and global health problems that at the end of the day have maybe been masked in some of our worry about the endemic, but will come back again stronger and have to be dealt with. So what I'd like to do is start perhaps with Prof. Nick Sebdalis, and I'd like to ask Nick, would you sort of kick us off by maybe commenting on what you think in your recent experience really has been the most striking application of behavioral implementation science that you've seen?
Joanne, certainly, thank you very much. Delighted to be part of this panel and to be having this conversation with colleagues. All our colleagues, a phenomenal number have joined us, which is great. I think for me, one of the striking features that, of course, implementation behavioral sciences have engaged with is the speed of innovation. You very nicely defined the sphere of work for implementation behavioral sciences, talking about the acceleration of uptake and application of evidence practices within health promotion and healthcare delivery. So what has happened over the last year and a half is a phenomenal increase in speed of innovation. We've seen it with the global vaccination development program, but we've also seen it within healthcare delivery and healthcare organizations. A very big example, certainly here in Europe, I'm talking to you from the south of England today, has been the increase in virtual applications, from virtual consultations with patients to virtual delivery of interventions, which up until a year and a half ago were only traditionally thought of as very complex interventions that could only be delivered face to face. So we have some great examples of innovating science that we are using to, for example, trialing the implementation of health champions who can help people with severe mental illness to manage their physical conditions, their diabetes, their high blood pressure, to think about health behaviors like quitting smoking, which we know is very high in those populations. Up until the pandemic, such interventions would only be delivered face-to-face. This has been now trialed virtually. Likewise, we're trialing interventions like group-based singing for mums with perinatal depression. This is something that had been trialed before only in a face-to-face context, and we're now evaluating how this can be delivered through virtual groups. And the answer is the preliminary data suggests that it is doable, and we're very much hoping that the effectiveness of these interventions will be retained in a virtual delivery format. Last but not least, healthcare providers have also been implementing innovations to communicate with each other. So, for example, we have seen implementation of apps within specialist hospitals so that one specialist can seek advice from another specialist through an app, whereas before you would have to go through your trainee and they would have to go through a switchboard. And at least in Europe, we often use bleeps rather than, very old-fashioned technology, reliable, of course, but very old-fashioned. Whereas now we're having apps, and therefore we can find out what other conditions are triggering those requests from one specialist to another. Say, from a psychiatrist calling up a cardiologist to seek some advice for an ECG, for instance, that has been remotely done on a mental health patient. So these are the sort of things that I think have really come upon us in the last year and a half. So the speed of this innovation is something behavioral and implementation science has really engaged with. And of course, the challenge for the future is to engage more and speed up the uptake of these innovations and their evaluations.
Okay. Great. Thanks, Nick. I think, both of those two things I think really struck me, that we're looking at the speed of a disease, for example, that is outstripping anything we've had to deal with before on a global level, but we're also matching that with a speed of innovation and healthcare integration that has also come up to match that. So I think I'd like to turn now then to David. David, with the work of BIT, what we've seen is sort of really engagement with policymakers, in healthcare long before COVID came up in many, many, many different areas. So what would you see, given your work around the world, really, as either on those two themes, innovation and integration, or anything else that you're seeing?
Great. It's fantastic to be here. And by the way, really credit to Professor Chong for the leadership, I think, in relation to NUS. If I go back a decade when we were setting up the Behavioural Insight team in Downing Street, and the White House had a similar team, we all thought that health and healthcare would be a prime area. And actually it wasn't for a while. I mean, there was bits on smoking and so on. The last 20 months has certainly changed all that, if there was any doubt at all. But before we get on to COVID, there are other issues too. I mean, good examples, I think, getting people to continue taking their meds or treatment. So a big issue for a long time has been issues like tuberculosis, where people don't complete their course. It's a massive issue. We found that you can use, essentially video kind of nudging and prompting, and we can get it to 80% compliance, which is the magic number. There have been issues around digitally assisted kind of guidance for both clinicians, for example, around prescriptions of antibiotics in relation to particular segments and beyond, where people are referred to, which can have big impacts, or even on the public health domain. I mean, sugar would be a good example. The obesogenic environment, I think the world has switched on that. The work we've been doing in the last couple of years has led to about a 40% reduction. It's just massive in sugar in drinks in the UK, and a lot of other countries looking at similar things. But COVID, of course, is a game changer in lots of ways, and no one would have chosen. But it's driven that every single of the kind of lines of defense are massively behavioral. Before you've got treatment early on, you're trying to, across the world, we're trying to sort out how to get young men to wash their hands, which at least in much of Europe was a relatively novel idea, it turned out. The kind of work in Japan around the CCC, can you get people to think about the underlying vectors of the disease and respond accordingly, or WWW, less well known in America, or we had hand space, which we developed. But we spent a long time, in fact, we've run more than 50 online experiments, often thousands and thousands of people, to test alternative messages. Which ones do people understand? We looked at the Singapore guidance on hand washing, which performed pretty well in many countries, we found, versus other alternatives. Let alone ventilation and all the rest. So the first line of defense, second line of defense, even when you start to you get your testing back up in scale, will anyone turn up for a test? When you ask them to self-isolate, will they self-isolate? What did South Korea do, which was very effective versus other kind of countries? We would test variations such as, is it more effective to call someone or text them? By the way, it turns out, certainly today, in countries like the UK, much more effective to call someone to make sure they're self-isolating than text them. And then even when you got the vaccination, you still have issues. Well, will anyone turn up for it? Vaccine hesitancy issues across the world. And lots of work about trying to work out the segmentation. Again, as Nick was saying, associated with, I think, unprecedented, very rapid experimentation, not only in the development of vaccines themselves, but also what's the right message to say to someone. So, for example, we have literally run trials with millions of people to try and figure out what messages work best for which segments. For example, in the UK, it turns out, use the word queue. You've reached the top of the queue. Britain seem to love queuing, and this is a very powerful cue to make people more likely to turn up. Missed opportunities, future challenges. Well, of course, COVID has raised many of those. Will some of the habits that have developed stick? For many Europeans, for example, wearing a mask seemed an extremely alien idea. They've now got used to it, and many people feel comfortable. Right, will that come back when it's necessary in flu season and so on? Will people stay at home when they're sick? that is actually against the social norm in many parts of the world. If you're sick, you should go into work anyway. And will that stick and will that change? Will we have a different attitude towards ventilation? Will that have knock-on consequences? And of course, as was mentioned earlier, really, digital would be a major example. Many patients and clinicians have got used to doing things digitally in a way that they haven't before. That offers all kinds of possible benefits, as well as the ability to A/B format, test, refine, improve. So I think anyone would have chosen what's happened in the last 20 months, but there's no doubt that I think it's accelerated and brought to the fore the idea of behavioural and indeed implementation science alongside more traditional kind of clinical practice.
And I think I was also really struck by your remarks in the sense that we have, unprecedented scale. We're able to test across populations, but at the same time, the work that you do is so context specific, and it still means that at a very local level, experimentation has to go on in very specific settings with very specific cues. So even as we're starting to understand a little bit more about the general scientific principles that drive some of these responses, doing that local level work with systems is still going to be really critical. And to make sure that some of these changes stick in some sense, right? How we integrate these into health systems going forward beyond COVID is going to be so important. Maybe and I think at this point, I think the best person to maybe remark on that would be, Professor Robin Milden. I'm going to turn to Robin. Robin, what do you think?
That was almost a perfect segue there, Joanne. That was fantastic. And in fact, the point on context is a major one, which I'll come to in a second, but a bit like David, when you sent the questions over, I wanted to have a think about the world before COVID, because certainly none of us asked for this. And some of the real breakthroughs that behavioural and implementation science has been able to make in healthcare include things like self-management of chronic health disease at home and in the community setting. So there's a lot of really good interventions showing how to do that. We were struggling to figure out how to make those interventions stick and be sustainable. So although we can show what works, the job sometimes of behavioural and implementation science coming together is to make sure that what works is implemented in a way that preserves its effectiveness and it's sustainable. Another example will be patient safety checklists to increase safety in the health setting and avoid severe sickness. Now, we know a checklist by itself generally doesn't work. Tons and tons of studies in that they work in very controlled trials, but they may not stick when they're kind of moved into business as usual real world settings. And often the use of them, that is fidelity, kind of drops over time. So what we've learned through the literature and through a number of trials is what other additional implementation strategies need to be added to keep the goodness and the effectiveness of patient safety checklists. A third example I'll give before I talk about COVID is diabetes and diabetes management and diabetes prevention. So again, we know a lot of really good science around what works, and we know also, particularly through behavioral science, what works to help people change their behavior to indeed get the benefit of those interventions. But what we also know is what David and Nick were alluding to, that stops over time. Maintaining that behavior over time is really, really tough. And again, without the addition of implementation strategies to maintain the how, we do lose the effect of these great evidence-based strategies that we have that particularly come out of these trials that David was referring to. And also implementation science made some major breakthroughs when it helped us understand how to not only test for outcome, but test for what implementation strategies work using really cool implementation frameworks like REAIM, which I know has been used a number of times in Singapore. That means reach, effectiveness, adaptation, implementation, and maintenance, and other ways to kind of guide the work you're doing. So if we can take all that good stuff and apply it to COVID, I think where behavioural and implementation science really needs to find its legs now is in this, I'm not even going to say post-COVID or anything, because I'm coming to you from Melbourne and I'm going to jinx it because we are still in lockdown. But as we move into the living with COVID, we need to help people sustain these behaviours so that we can all get to some level of good health and normal interaction with each other. And not only that, it takes more than just thinking about how to sustain behaviours. We need to figure out what is the systems and the infrastructure around people that needs to change to help them maintain those behaviour changes over time? How do we, what can we know from implementation studies that will be able to ensure that we can help as best we can achieve some of the gains we've made, particularly in the lockdown? So I think there's a lot more to do, and I think some of your questions are going to go there, Joanne, now, but a lot more that the sciences can offer now to help with, going into 2022, 2023, and hopefully seeing each other in person one day again, maybe.
Well, we very much hope so. I mean, I think, okay, that's actually also a perfect segue to some of the questions that are coming up in the Q&A. I think digital health in particular, I think, is really a focus for many of us today. And I think David also referred to, I think, us, the fact that we've been working in this space long before COVID, and those really sort of exciting experiments, for example, about TB compliance in Europe, even before COVID came along, laid the foundation for a lot of the scientific questions that we're asking now, but we are asking them at an ever increasing pace. And as some of the Q&A are coming up in the chat, one of the questions that we also have are, given that we haven't resolved the digital divide, and in many parts of the world, that kind of infrastructure is catching up very slowly, how do we deal with some of these new emerging issues such as equity when we're moving forward at this pace? Maybe I'll turn to Nick. Nick, would you address that question? How do we make sure that as we're moving innovation forward with the frontier for humanity, that we don't at this time leave people behind who don't have access to things like reliable internet connections or individual smartphones or some of the privacy issues that might be coming up with these innovations as well?
Yes, thank you, Joanne. And this is really a very pertinent point. This one that we've been trying to deal with for the last year and a half for sure. So what we're doing in this space is that we've actually established panels of patients and service users and the wider public, and we consult on a sort of regular basis at the time when the projects are being considered and the directions for research and innovation are considered, because if we're doing it later, further down that sort of research innovation pipeline is sort of too late. So the message that's coming from our service users and the patients is basically just do not forget that we're all individuals and we live in very different individual circumstances. In fact, I think I might be painting an even bleaker picture here, but in fact, COVID has not only sort of expanded, but also developed new inequalities in terms of digital access. And we know that there are differences, not just between countries, but even within a country, even within a city, large cities, the size of London, many European or US cities, and indeed places like Singapore, you've got wealthy, IT literate people who, and I'm not talking about millionaires, I'm talking about people who can have the privacy of their own house, their own room, their own stable internet connection and knowledge of how to use that to access healthcare. And these people have been riding this wave of innovation, and it's been working really well for many of them. And yet on the other side of that spectrum, you've got people who haven't got any of that. They don't even have privacy, let alone even if they did want to access digital services. So the message, there is no short answer to the question as to how do we address this overnight. The interesting thing here for me is that this goes well beyond healthcare delivery. This is a wider societal sort of issue, and we need to look at this in a broader setting. The conditions of work, the conditions of housing, and therefore they have impact on health and health behaviors. The message from our patients and service users is really very clear. As we're moving on to this sort of digital innovation sort of era, and we're putting a firm footing in there, people are saying, just don't forget that not all of us are on the same page, not all of us have the same capabilities. So do not just blanket offer a digital consultation as an entry point to the health system, because this will basically automatically exclude several people, and it tends to exclude the most vulnerable in society. So people are talking about these hybrid models of healthcare delivery, whereby we tailor the delivery of healthcare, say, for example, consultation, to the needs and abilities and the circumstances of our service users. So for some people, this will mean digital because they prefer that. Cuts down on their traveling, cuts down on their risk for infection. They're able to do so. For other people, it means that we need to see them for the very same condition. We need to see them face to face, the way we've traditionally seen them, and so on. So we need to start tailoring. I think that's the direction we're going. People have been talking about personalized medicine in the context of drugs. I think we need to start tailoring the delivery of our services, and we've got the drive to do so between face-to-face and digital delivery models in a much more nuanced way. It's not one size fits all. And I think we really need to do some work with our local communities. This is where context comes back to identify for which service users this tailoring is absolutely imperative and urgent, because otherwise we're risking here to create large cohorts of underserved populations, which we really don't want to have, both from a public health point of view, but also from longer term disease management. And we have the means to do so. Right.
No, absolutely. And I think, conversations about the social determinants of health, have not disappeared simply because we have this sort of, COVID epidemic on our hands. It really has exacerbated many of these new social determinants that we really have to worry about. I'd like to maybe turn the question to David and say, David, in your experience, when we design for diverse populations, or when we design things in practice for population groups that may respond differently or have different needs, how in practice do you do that? Or do you have any examples where you can speak to about how we marry the need for large population-based interventions with very specific differentiated needs within groups?
Yes, I mean, bear in mind, of course, it's applied even as it were in conventional clinical questions. A lot of drug trials were done on men and not on women, and were they adjusted? And actually, you need to do some of those kind of adjustments. I think one nice illustration I found, I mentioned in passing earlier, some of the work on antimicrobial resistance, particularly reducing the overuse by clinicians, and indeed patients often asking for antibiotics, which is true in many parts of the world. And as you all know, in fact, not just in healthcare settings, but often in animal husbandry, actually, of course, is a big part of the issue. So we've done a number of trials, fairly well known, it was published in The Lancet a few years ago. We're giving clinicians feedback about their use of antibiotics relative to other clinicians, and we found very powerful effect in relation to reducing overuse. But there are some populations where it's underuse. So we did a trial relatively recently in New Zealand where it was true, we had some of the same issues with the majority white population, overuse, and you give feedback. But in relation to the Maori population, when you looked at it, the issue was the other way. It was underuse of antibiotics, under treatment. So we were able to give feedback on both populations to clinicians and get the adjustment, as it were, in both directions. So that's a very nice real application of evolving that. And the effect size, in a number of places have been roughly sort of 10% plus in relation to the movement, and a very big deal that follows from it. I just want, on the equity issue more generally, let's also bear in mind, there are equity issues, of course, within countries and between. There are also some pretty big issues which are around us all the time. I mean, smoking is rising in the world. People forget it's falling in some Western countries. In the UK, we push very hard on it. But, 7 million people die from smoking most years. It's like the same number or more in relation to COVID. It's just astonishing. What are we going to do about that? And it's rising. And that has a very nasty equity issue in many countries, differentiated. The last point, on a more positive note, I would say, is on the digital side. So we've got to work in a lot of places in the world. And one place we've done quite a number of trials is within refugee camps. And one of the striking things is even in a refugee camp, where there may be no good access to water sometimes, there's good access to mobile phones. Most people have a mobile. It's quite stunning, actually.
Right.
So that may be changing quite fast. It doesn't mean, say, there are very lots of places in the world. We're doing a trial. We're just waiting for results on hand washing in Bangladesh. We're doing in the field, and how do you actually set up, standpipes, and how do you queue and encourage people. But the digital actually is a major asset. Let's not make any mistake. Many people who have access to relatively little in other ways are able to access what NUS or the Mayo Clinic is doing out on their mobile phones. So one question becomes, well, what can you get someone down that? Well, you might not be getting them a drug, right, or whatever, but you could actually get them something else which will help them. So we'll see as to whether that turns into a great leveler, but it's certainly a significant asset.
Mm-hmm. Terrific. Yeah. And I actually really appreciate what, the insight that actually at the end of the day, we make a lot of assumptions about populations, but we can continue to be surprised by conditions on the ground, and making assumptions about what people are ready for or not ready for is also something that actually sometimes is an issue for us as we go into intervention design. And the empirical work, the empirically driven, approach that you have, I think it's extraordinarily effective for that reason. We don't impose our point of view on people. We really go into it in the spirit of inquiry. I think I'd like to turn to Robin actually at this moment. I think with respect to implementation strategies, a number of the questions that are coming up in our chat are really about implementation strategies, taking digital health again as an example. What kind of strategies do we see, right, in order to make that stick ready? So once we do this, right, for example, some people in the chat are asking about workforce readiness for digital health or engaging patients and their families for digital health. What kind of strategies might we see that actually might help us in a very concrete way to talk about getting these into the healthcare system on a more permanent and sustainable basis?
Yep, can do. And I do want to also address the equity thing. It's a super hot topic in implementation science. So let me try and take to, I actually did a little bit of looking at this for a project and some conversations we were having with some people in Singapore around trying to increase the uptake of apps by medical doctors and then by population. And when you go and have a look at the evidence, fortunately, there hasn't been a lot of really good systematic reviews or multiple trials to say too much. So if you think there's about, 70 odd implementation strategies you could try and use to implement to increase the uptake and implementation of any innovation. We know from some of the BI literature, some prompts work. We know people's perception of that it's usable and that it's acceptable to them. So we know some of that the actual innovation itself needs to fit with what the people need to do. There's a thing called relative advantage. We talk about a lot in implementation science. If people don't perceive that the new innovation they're being offered is better than the other thing they were doing before, it's very tough to get uptake of the new thing. So it's sort of building people's belief that there is more advantage to doing this than not. But we have a long way to go. And I would say in implementation science in general, and David and I have actually talked about this before, we really need to move to conducting multiple trials of implementation strategies themselves and what works to maintain the effectiveness of an innovation that's shown to work, not just whether the innovation works itself. We do really need to take some of that, even that A/B type trialing approach and accelerate our understanding of what implementation strategies work. And so I'd encourage anybody that's interested in that. That's certainly something BISI is very, very interested in pursuing across multiple trials. I will also say on the equity point, implementation science and behavioural science was built to address equity issues through a couple of things. There's a big focus in BISI type work on reach. That is, are we reaching the population we intend to serve, particularly if we know through early trials that we have something that does work. And so focusing on reach from the beginning and really targeting that as an implementation outcome. We also, the behavioural and implementation science literature, and it goes back to the point I was making earlier, what we do is try and design interventions with vulnerable people in mind, but also what implementation strategies will overcome barriers for them accessing this. So what are the things we can put in place to decrease the barriers to limited access to these innovations and increase their uptake? And that's really, if we all put our energy towards that around equity, I could really see these sciences contributing to decreasing that. And also developing a little bit of a science of adaptation. So we get a little fixated on when we implement things across settings or across contexts. Sometimes you'll hear the word, adherence must be the same, or we must show absolute fidelity to the way it was implemented somewhere else. Well, really, the science isn't showing that to be quite true, and that some level of adaptation for context does actually help people implement it more effectively and more meaningfully. And so we need to get better at how to do adaptation without taking away without adapting it to a point that you've lost the thing that was effective in the first place. And really sort of taking that strong focus of implementation and equity lens at the start. So I think, but again, there's implementation science sort of developed as the science behind behavioural science, and then two, they incorporate each other. But we've got a real way to go to learn a lot of the points I'm making.
Great. I think I would like to pick up maybe on one of the points that you made, I think, about really how behavioral implementation science work together. I mean, one of the things that we've also talked about is really how, at the end of the day, we generate all of this evidence and we want to make a change. And so bringing them together is really about trying to be most impactful in creating change in health systems. I mean, a number of things in the chat are really about how we then, as we interact among ourselves as researchers, how we then also take this directly to policymakers. So what platforms or what avenues do we have to actually change behavior and mindset at the policy level? Now, I know David's work is much more immediate in this regard than some of the other work that we do as academics, and we hope that we accelerate the rate of adoption. I think one of the things that people really are wanting to know is what lessons do we have from the period that we're living in now, but how to translate research into practice more effectively. What do we see as these ways of changing behavior, not just of people, but of decision makers within the system? Maybe I'll start with David. David, with your experience at BIT, and the genesis of BIT is very special in this case, right? What do you think are the key platforms or avenues that we have for actually communicating with policymakers in this environment and affecting change effectively?
Yeah, thank you for the question. Well, you're right. I mean, we were relatively unusual in that we were built inside a government and work with a lot of governments kind of directly. I mean, one of the most important points, Janice, a remark you made almost in passing, which is that we think of it as humility, but often there are surprises. People don't behave how you think they will. We have so many assumptions. I mean, clinicians often do. We do about each other. Policymakers certainly do. Even to go, I mean, we just touched on briefly about around work we did in refugee camps, and one of a good hypothesis, it was thought that you want to get parents engaged in, how can you encourage parents to engage, to parent with their kids, get them excited and interested in doing things with educational and health benefits. And it was presumed that you make it fun. Everybody, that was the view. And we thought, is that really true? And so we actually ran a trial asking people, do you want to come and take part in this kind of edutech, if you like, by your phone? And one sort of invitation was talking about, that it's going to be fun to do with your kids. And the other one was talking about it's good for your kid's brain and science, basically. It turned out that was much more effective, significantly more effective in terms of getting people in a refugee camp to want to engage in this content. So why I mention that example is that it's trying to bring back in a notion of humility, is to see the things, the kind of priors that you may not have, be aware of, and say, well, what would we do differently? So I spend a day a week as a national advisor on what works, working with policymakers, trying to essentially build institutions, but also a broader understanding, which is whatever issue you're working on, particularly in health, but many, many other areas, what are the questions which you don't have answers to? What are the other alternatives? And just kind of keep testing. I mean, as Robin was also kind of saying. The other thing is, there was a question also in the chat about policymakers. One report we wrote a couple of years ago, finally to kind of the anniversary of Nudge, was on behavioural science applied to policymakers, who turn out also to be human beings and are subject to many of the same kinds of bias. I mean, a simple one would be overconfidence. If you think you're going to do this big policy, politicians then say it's going to be X, Y effective and so on. And certainly in Western countries, tend to overestimate the likelihood of success. And the more senior you become, overconfidence issues become more severe, interestingly. That's probably also true in relation to the medical profession, I suspect. As you get very senior, it's harder to listen to other kind of possibilities. So there's lots to be done. And then also almost on a structural level in relation to health. I mean, a very interesting question is looking at the, sometimes called a Moore's law, is that the diminishing returns to health investments in kind of traditional pharmaceutical type interventions, which we spend billions on, but basically every 7 years is roughly halving, I think, the returns, and bolstering it with, well, where else are those returns? And many of them do look like they lie on relatively affordable behavioural interventions. either to try clinical uptake, but also to change people's behavior, to make the world an easier place to be healthy in. And the penny is at least dropping with some policymakers, but that's still quite a big jump, because you think, well, actually, we understand what health is. We just pour money into this end of a big secondary healthcare system. Hopefully good things come out the other. I hope we can get a bit more nuance in that. And so the final thing is that it's sometimes through the actual lived experience of the senior policymakers themselves. So the UK's Prime Minister Boris Johnson, many will know, actually had quite a bad dose of COVID. It also really brought home to him personally the issue of being overweight. He's a few more pounds than he should do. It's really changed his view on the topic as a policymaker about we need to do more about that, not just on the traditional healthcare side.
Yeah. No, I think that's really insightful. And actually in Singapore, we had a very similar experience with a very senior member of our government who experienced sort of a major health issue. And this actually triggered a very significant healthcare financing reform, because only at that moment did he sort of understand like the burden of healthcare financing. So sometimes it is the case that lived experience is the key that opens up some of these policy discussions. Perhaps Robin, can I turn to you?
Yeah, I'm still thinking about David talking about the Prime Minister's weight on a webinar. But I also think timing is everything. And for policymakers, being able to, in our experience anyway, being able to provide them with something in a timely way that solves some of the issues that they're facing, which goes to the lived experience point. Sometimes we can come across a little bit complicated. We can put a few too many barriers ahead of them in terms of choosing what works and then figuring out how to get it implemented, or we're just a little slow sometimes in the generation of some of that evidence and then being quite succinct in our answers on implementation. But policymakers recognize the implementation problem they're facing. They recognize issues with sustainability. They recognize, especially when you've been around for long enough, that sometimes we just keep repeating the same thing. So I think the better we get, and I do think behavioural science has led the way on this, and implementation science has got to get better, is to make these concepts really understandable, translatable, usable, doable, and something that will benefit from what they're trying to achieve. I think if we don't do that quicker and better as a profession, we will continue to conduct enormous amount of trials around what works in terms of helping people change behaviour or do new things. But I do worry that we won't get any further implementation of it. So we're just sitting on this great body of science that shows how to get certain innovations in place and outcomes, and we aren't really benefiting from that because trials done, things been published, off we go. And I think policymakers, in our experience, again, respond quite well to the let's focus on really getting this implemented and sustained.
Yeah. I think the issue here also is that with healthcare, right, we have dilemmas that are very challenging to resolve. We have the iron triangle of healthcare: cost, quality, and access. And sometimes at the end of the day, it's about making difficult choices and trade-offs. And so everyone loves, first of all, a simplifying narrative, and everybody loves a solution, and everybody loves something that is faster, better, cheaper. And then making those choices, I think for a policymaker or any human being, choosing 2 out of 3 is very challenging. And we come back down to the overconfidence bias, sometimes the over-optimism bias, right? Or the sense that something must be done. So we have a little bit of an action bias there where we feel like there is a solution, I must find it if I try hard enough. And healthcare, I think, is uniquely challenging because at the end of the day, sometimes these are dilemmas that have to be managed, and we don't have quick and easy answers. And that's very difficult to present to policymakers with their own biases, but also their own practical deadlines. I think doing the best that we can is not easy, right? Nick, your thoughts?
Yeah, this is really a very interesting conversation. I would certainly support what David and Robin have been talking about, and just to throw in a practical angle that's driven by our own experience as in our work in England, where our centre is now sort of 6 years old. So the interesting thing is, Robin sort of hinted at this earlier when, Robin, you were talking about engaging with stakeholders, and indeed David has done the same as well. Policymakers, just like scientists, we tend to put them on one end of this sort of translational continuum. We say we have, early phase, we have discovery, so research, and on the other side of that, the other end of that continuum, we have implementation, research, and scale up and sustainability. But the reality is that the scientists, as people like ourselves and the policymakers, are not necessarily or should not necessarily be sitting in different rooms for years until the evidence becomes available. And then we go and say, right, we've got a great intervention, we've got a great solution. Do you have a problem to which this might fit? This is rather exaggerated, but unfortunately, in the mind of some of our more basic science sort of colleagues, this is their reality. Our experiences of the last few years, we've put an enormous amount of time into developing relationships with what you would call a policymaker. Now, a policymaker might be, the chief executive or the executive team of a hospital or of a regional healthcare system, like those that we have in England and in different formats. They exist in different parts of the world, pretty much in all parts of the world. We're not waiting for a crisis to happen to then try and find what intervention we can pick off the shelf and apply. We're developing that conversation. We know the problem. We have a sense of the problems as they arise. And therefore, some of the more applied parts of research, I'm not suggesting that all research should always be problem-orientated and applied, but there is part of it, and in fact, globally, is the most underfunded part of it, that is needing to sort of tackle real-life public health and healthcare delivery problems. So my suggestion is that it's always, and I know we have hundreds of attendees, some of whom are scientists. If we're waiting as scientists until we've got something ready to go and present it to someone, is way too late. It's way too late. We need to be thinking about designing our studies in conjunction, or some of our studies at least, in conjunction with the people who can then apply those tools. We need to be doing some of our qualitative in-depth work, or even some of our trials, with the people who are going to use the tools. These are frontline providers, but there might be managers of services, there might be funders of services. All these people manage policy at different levels. So we need to be working much more closely in identifying what the research should be addressing in the first instance. So then we don't have this paradox. So here is a solution. Can you find me a problem to apply it to? Because the solution and the problem are streamlined. When the solution appears, there is a fertile ground for it to be applied to. The reality of doing so for many people based in universities is that it's challenging, because this is a sort of unpaid hidden work. We're not paid to be having meetings and dinners and lunches and coffees and teas with our policymaking colleagues. But this is where the stakeholder engagement actually happens. And that's really hard to sort of quantify. But without this web of relationships, we never get a chance to see what the real problems are and how the solutions can be developed that actually fit and are deliverable, implementable, and sustainable these problems. So my call to everybody would be that we need to work more closely together rather than keep stakeholders apart and then only remember them when we've got an intervention that's delivered, evaluated, and we're seeking to establish a pathway to implementation. Because I would argue that that's way too late to be doing that.
Yeah, thanks, Nick. And I think that also addresses some of the remarks that come up in our panel about how people sort of juggle what academics typically chase, publication, grants, research, that are on a very different timeline with very different metrics to the kinds of needs that we are seeing emerging so quickly. I think the other thing, which is really, I would add to that, is that what's really important for us in our research is not just to engage with the policymakers, but really on our research studies to engage with the ground level stakeholders, to continue to build up patient engagement networks, for example, family engagement networks, to really understand at the end of the day how the end users of our research or the end beneficiaries of our research are working together, with us in order to co-create some of these solutions. Not just because it's an exciting way to pursue research, but really because ultimately, if we want things to be sustained and context specific, that's really the only way to go. We have so many problems today that we really can't think our way out of. We have to sort of strike this new balance of thinking and doing. And I think, with the three panelists that we have here, all of you have pursued that. I mean, albeit in different settings, but it really sort of captures the fact that behavioral implementation science requires that we understand both these academic scientific standards and the real world around us. Right, we are actually running out of time. It's a very short panel today, which has been very exciting. I could be on this panel literally forever. But what I want to do is just ask everyone here to maybe sort of spend a little bit of time just reflecting now. I think one of the panelists, one of the Q&A have come up asking, so what you think, based on your experience, is the most exciting or most important aspect of behavioral implementation to address going forward? So if I could ask each of you in turn at this time just to say, looking into the future, where do you think we should place our energies, or where are you personally going to be placing your energies or focus in the immediate future going forward? What do you think is the area in which that lever, right, of our effort is going to pay off the most? And maybe I'll turn to Robin, and then David, and then Nick at the end. So Robin?
So, and I can see we're fast running out of time, so I'm going to do this as quickly as I can. I think, again, I said this earlier, behavioral and implementation science is kind of built for where we are now. And I think the real opportunities as we sort of come into the next phase of how we all live with COVID is to figure out and be able to make recommendations on how to make some of this change stick, and then how to continually adapt it for other contexts and ensure people are getting access and able to benefit from some of the innovations that are helping us get through COVID. And there's just so much we could be doing here. So we could be supporting work around telehealth that Nick was talking about earlier. We could be talking about one of the big topics in implementation science is how do you scale? So scale is the definition of scaling loosely is getting to about 70% of your intended population. How do we do that? It's one thing to figure out how to implement in pockets and sustain it in pockets, but how do we take that to scale across multiple contexts, and how do we maintain that in a way that people can benefit? How could we more systematically look at barriers ahead of time to what's getting in the way from sustaining implementation of things that work, and then use that to design implementation plans, test and trial them, and again, continue to kind of benefit from the innovations that are helping people get back to their lives and address things like David was saying, smoking, obesity, all the other nasty stuff that comes with being a human. So there's a bit to do. Thank you.
Thank you, Robin. David?
So look, in many countries, behavioral factors, pretty familiar on smoking, drinking, diet, etc., could give on average probably about a decade of life back to people. So that's a very, very big prize. Within that, by the way, clinicians are often the most powerful messengers. If Professor Chong says to his patient, you better quit smoking, that's about as good as we can get, right? But one of the puzzles is also assembling those pieces. So I know there's always controversy about that. We've advocated e-cigarettes. We believe they've been attributed to a lot of people. They're the most effective channel, basically, to get people to quit. The most effective message as a clinician, the most effective known channel right now is the e-cigarette. We can't get these to come together very easily. A lot of clinicians are quite hostile to e-cigarettes, right? And we don't in most places have basically a clinical grade one that can be prescribed. So it's a substitute behavior. So assembling the pieces is very, very powerful. And that's a very, very big prize to go for. And one of the interesting things about what NUS is doing is to try and say, well, can we have also, tomorrow's generation of clinicians who understand diet and these wider set of factors, and then can also advise policymakers as well as patients to really improve their health. The last thing I just mentioned, in terms of opportunity in the last couple of years, one thing is very striking in a number of countries, the number of people in the public, volunteers and others who've wanted to help. They've wanted to engage in clinical settings. They've wanted literally to stand on lines outside and help people get jabbed or whatever it will be. And often people have been puzzled what to do with that. I mean, we've literally had like 1 million people in the UK, and the healthcare system didn't know what to do with that level of goodwill. So that's another thing maybe we'll all ponder. And if people have got good answers, let's come back to that as an interesting topic.
All right. Perfect. Nick?
Thank you, Joanne. The beauty of being the last one to comment is that all the important things have actually been said. I don't need to repeat any of those. What I would say is that I hope that part of what we can do, both individual centres working with BISI in Singapore and more broadly, is to keep this message that COVID, the work that COVID has necessitated, has really made very clear to people, both in the sort of service user and patient side, but also on the provider side, that change we can implement change, and we can do so pretty rapidly when we need to. So we don't need to have this. It's often in complex healthcare systems like the one in Singapore, like the one in European countries or Australia. I had this experience. Often people felt, especially the front line, that everything is too difficult, everything takes forever, everything costs millions. But the reality was that overnight we changed the way we do things because of COVID. So for lots of people, this reinforces this concept of change efficacy. We can make change happen, and we can work with the system rather than sort of against it. If this is a legacy that we as behavioral implementation scientists can reinforce and take forward, I think that would be a really powerful strategy to achieve what we need to achieve, and to attack the areas that Robin and David and yourself indeed have highlighted that we need to be attacking for the next few years to sustain the good things that we've and the good innovations, the useful innovations that we've introduced because of COVID, and to actually discard others that are not effective or are not efficient, and they're not really promoting outcomes and health outcomes and healthcare provision. So I think this self-belief is something that hopefully we can reinforce and maintain within our staff and cadres of healthcare providers across the world.
That's lovely. And I really like how that brings together what Robin and David said, which is that we're really looking at making our healthcare systems more resilient. COVID has happened to us, but we are not defined by COVID. And that part of what we've seen is that we've looked at unimaginable things, but we've also done unimaginable things. And in some sense, we're looking at scaling things at a level we've never thought about before, but we have resources like actual human beings who want to come to us and that's a resource that we've also never thought about before. And so we have new horizons to deal with, we have new resources, and science has to adapt. And it looks as if we're doing that in a very dynamic way. One of the things I think, again, I applaud about having something like BISI is that we feel that putting these tools, behavioral and implementation science tools, into the hands of every clinician is a great place to start. Obviously, it's a long journey, but at the end of the day, I think we're well prepared to take those first steps forward. So on that note, I'd like to close the panel. I'd like to thank all three of our speakers very much, as well as Prof. Chong and the amazing administrative team that helped to support the session today. We've come to the end of this panel discussion. Our administrative team would like me to say that please kindly fill up the post-event survey form as you leave. This is Singapore, so you must fill up the survey form. There will always be a survey form. And please, the chat room is also open, so you can leave comments in the chat room. Do follow the center on Twitter or LinkedIn. There will be another webinar on the 22nd of October, so we look forward to an active series of participation. Thank you all for being here today and for participating, to all three of our speakers, especially, as well as to all the members of the audience that have been here with us today. And we look forward to seeing you again. Thank you so much.